Hello, I'm Dr. Paul Bunge. I'm an internist in Olympia, Washington. I'm going to talk to you today about outpatient early COVID-19 treatment. So my goal today is to help you by the end of this talk to become able and confident, as long as you have some resources at your fingertips, that you can tell your patients about these 4 available treatments, choose one and order it for your patient, and maybe reduce their risk of getting severely ill and possibly save their life. So COVID numbers are way down right now. The hospital has less COVID patients, which is very encouraging, but still hundreds of Americans are dying every day, even though there's new treatments available and we can help reduce their risk of hospitalizations and deaths. So this is very important, and actually may be more important with the numbers down because less people are thinking about it, and we have to target the numbers by finding those people who are infected and mildly symptomatic. So the NIH has given guidance on which treatments to use and what priority. This is based on available data and studies, which is difficult to apply as there has been changes in the virus in some cases since the studies were done. And none of the treatments were compared head-to-head in any of the studies, but I think the NIH did a fine job in analyzing the data, giving the best possible practical advice on what to use. And of course, you can go back to the NIH webpage and they've presented some of their data and how they worked on it. So in order to talk to about these treatments, I've talked to various infectious disease providers, nurses, pharmacists, and Dr. Rachel Lucas, a pharmacist, has helped us with our algorithms. As you can see on the algorithm, there are currently 2 monoclonal antibodies available. I'm not going to talk about the Evusheld. This is a preventative mix of monoclonal antibodies that's long-acting and specifically for people to prevent COVID-19 in high-risk immunosuppressed folks. So we're going to not talk about that more than this. We're going to concentrate on the main algorithm, the treatment side. The first thing you should notice is again, this question of who should be treated. It's the people at high risk of developing severe disease. A common mistake in our thinking about these medications, and I've heard many patients say, and doctors agree, that this person does not feel that bad, we're not going to have to treat them. But these medications only work in this early stage. So you need to remember the 2 phases of COVID-19 disease: the non-severe stage where the body is developing its immune response, and the severe phase of the cytokine storm, the lung damage, where people are sick and in the hospital. So as you know, less than 20% develop this second stage and this risk of hospitalization and death. So we need to target these people based on their risk for progression to the severe phase, not on how badly they feel right now. The first phase is when the viral load is growing, and that's when these medications are effective to reduce the viral load and reduce the risk of going to the second phase. Within the second phase, that's when the immune system may be a little bit overreacting, so that these medicines, especially monoclonals, don't work as well. And at this point, we may be giving them steroids, right, to cut down their risk of overreacting and inflammation in their lungs. Here on the algorithm, you can see one of the things is the patient's oxygen level needs to be normal or not dropped from their usual, because that's maybe a sign that they've gone on to that severe phase and that they need maybe hospitalization or some other treatment. So the risk factor list we have. Also, you might think about other people who are not on the list of risk factors, especially those who've never had a COVID-19 vaccine, or minority groups such as African Americans, South Asians, and Hispanics who have higher risk of developing severe COVID. And so think about that, but let those people know if you decide to treat them, they're not on the list. So they may, you're not going by the current recommendation from the NIH. So you have decided now that you're going to treat your patient, they're at high risk, and they're in the early non-severe phase. What are the treatments? So this is a little bit of a moving target, but I believe you can use this algorithm with confidence, because what's changed is the monoclonal antibodies. As they've got resistance, the other medicines have not really changed over yet. But some of the various internet sites are not staying up to date. Even up to date is not as fresh. And so we have to use our algorithm and watch the NIH website and we'll try to keep this up to date. So Paxlovid is first line. The three things that you need to know about this medication are the drug-drug interactions, the renal disease risk, and GI side effects. First, this medicine interacts with a long list of drugs, mostly interferes with their metabolism. So watch for things like, for example, amiodarone. So if somebody's on amiodarone, you give them Paxlovid, their amiodarone level goes up, and then they have a problem. So just don't give it to that person. So there's some meds like that. Some meds like statins, you could hold them for 5 days so their level doesn't go up. So you have to make sure you check the list of meds either by using an interaction program that we have on this algorithm, or the list of medicines that it interacts with. That's for example, an UpToDate, and just go through them one by one and make sure that they're not on that medicine, or if they are, what are you going to do with that if you can stop it? Secondly, it builds up in renal disease. So you don't want to give it to people with renal failure because your Paxlovid level go too high may cause high risk of liver damage. So there's an adjustment between GFR between 30 and 60, and a hard stop if the GFR is less than 30. So you have to use your judgment on people, for example, who don't have a known creatinine that's recent. If they're not at high risk of kidney disease, you could consider giving that medications. A lot of people do. And if they're at higher risk, saying, okay, we need a creatinine, or we move on to the next one. The last thing you really need to talk to these people about, there's risk of GI side effect, especially dysgeusia and diarrhea. So a lot of people, in the studies it was 5 to 6%, but a lot of people are stopping the medicine because of this side effect. They're surprised by this horrible, horrible taste in their mouth, and we need to just warn them, and then they're more likely to stick with it, and it's only 5 days. Many pharmacies have these pills now, but you need to check with that particular pharmacy before you order it. Second line medicine, if they can't qualify for Paxlovid, and within 7 days, is remdesivir. This is a viral medication, but the problem with this one is that you have to have it for 3 days IV. So you may recognize it. We've been using it in the hospital, but there's not a lot of places that have it available for outpatient therapy for 3 days in a row. So most of the time you can't get it because of that, and you have to move on. Third line is bebtelovimab right now, but what I would remember is in this box, it may switch out with new monoclonal antibody, or if we get another variant that's good with one of the older ones, so this may switch out. You might just remember it's a monoclonal antibody, and make sure that availability, you have to find out where this is available in your community, which hospital has it, or outpatient infusion center. And if there's not in your community, you should advocate for your community to have this available. It doesn't have risks of interaction with kidney or renal disease patients. It's a protein. It has the risk of having an immune problem with an antibody. It has to be given. This particular one is an IV infusion over 30 seconds, and they watch them for an hour after that. If that's not available, or they don't want to take an IV, the fourth line treatment is molnupiravir. This is another pill, has to be started within 5 days of symptom onset. The reason it's so low on the list is that the main study that was used to show how this worked only reduced hospitalization by 31%. 31%, although the Paxlovid study reduced it by 90%. Again, it wasn't the same study, but because it seemed reasonable, and it seems reasonable to me to use this as kind of the last of the treatment options, but still works. The other problems with this, you can use it in adults. It has problems in kids because of cartilage growth interference, and it's very teratogenic in animals, so is thought to be very off limits for somebody who's pregnant or could become pregnant or breastfeeding. So you need to watch out for that one. Of course, these things change rapidly. There's convalescent plasma shown to be useful, of course, not really available for outpatients. So stay tuned for further developments. For further resources, you can see a list here, and I've put links on www.anewvirus.com, very simple web page there, as we're updating some other ones. And all the best to you in this fight. Thank you.